Well, we're back and recording, and so 1,000 apologies for not being rather. I just want to. So, what I wanted to do, if you got a chance, I'm just showing it to you here at the bottom of week one, and I don't, it's not uh, here with regard to this lab. Okay, I recorded this, whatever that turned out to be. So that would have been on Friday. I would have recorded that, and so I tried to go over the rest of the axial skeleton and show. And I'm going to show you a few things from it now, as well as the remainder of the appendicular, and then the appendicular, which I started a little bit with the clavicle and just started with the scapula. So we're going to look to do that today, and I'll try to get through all of the bones. Because of that, it's going to be much more effective if we have yet another week next week to use some time for reviewing the bones after you've had a look at them, and then so 2 weeks from today, whatever it is, the 25th, I guess it's the 11th, right? And what it says over there. Then we'll do the practical and be done with that. Okay, so we'll get it all in, and I want to have, and even next week, as well as having time for the bones, I'll probably do a fair amount. Maybe I'll get a chance to introduce joints today, and we'll go from there. And the only difficulty what is trying to make sure you have time. I do not know. I'm surely unfamiliar with your schedules, but typically the lab is open Monday. Most labs are Tuesday and Thursday, as you probably know from your friends and colleagues here. Most of the anatomy and physiology labs are then, with the exception of on Monday afternoon, I do an advanced anatomy lab. But I'm around here, so if you want to make arrangements, I can schedule to leave. I can be here. I don't know what your schedules are. Maybe from 11 to 1 on Mondays. This Monday will be hard because we've got students coming in on campus, and I'm working with one of my biology colleagues with high school students. We're doing some stuff here. They're going to be all over but we'll figure it out. So I'll try to get some times down, send them to you, and if they don't work for you, let me know, and I'll try to make arrangements. Okay. Announcements 101. So get a chance to listen. This wasn't that long. It was about, you could say 33, 34 minutes of that type of stuff. And now we'll get back to what we're doing today. So we'll continue to record that. And this is kind of, and I went over this stuff, but it wouldn't hurt just to show you sort of generically. And you're going to need to know these parts of the vertebrae, and you're going to need to know sort of the features that are there. So this is anterior. This is what it looks like in front with any of the vertebrae, and I pulled out a bunch of bones here. With any of these, this would be very, very similar to it. You can see the anterior view, the body is up here. Okay. It's funny because here, when we used to have to work on people's backs, we went from back. The trouble is that there's so much ligaments and muscles here, it's very challenging. So nowadays, particularly in the neck, they go to the front. It's really just like bone. So it's nevertheless, it kind of looks like that. So you can see the body, which is the mass, really that holds everything. The opening here, and it's not, they're doing it generically, that vertebral canal, or vertebral foramen, they all stack up as well as the vertebral canal. That's for the spinal cord. This is the spinous process, which is why we call it the spine. It's really these things that protrude. And the transverse process is going one side to the other side. And kind of sticking up and sticking down, they're called articular facets. And their whole job is to basically work with the guy, like you get ones that meet, kind of like relatively speaking. So kind of like something like this. So even though these are not the exact mates, the superior ones from below and the inferior ones, they come together, and that kind of allows us to roll these motions. So, and what happens with that intervertebral disc, and that was in the earlier presentation, it allows that disc keeps this open. And that's where the spinal nerves come out. So when a disc slips, per se, it kind of does this. It goes one way or the other, and it narrows that opening, and it pinches the nerve that goes through it. That's kind of what happens. So you have all these tiny little joints. A little bit of motion here, a little bit of motion here, shifting, gliding, sliding, learn about our joints. And all of that leads up to the amount of motion we have if you're swinging yourself from side to side, if you're striking a ball or an object, like limited attempts to play golf. Like that. So those are the structures. The reinforcement here around the canal, these are called lamina. And the ones that come from the body here and here are called pedicles. So lamina, so these are the pedicles, and back here are the lamina. So those are some parts to be familiar with. And then the other sort of hard part is looking at the specific vertebrae. This is very small. So you could just say this is a cervical vertebrae, and they're quite small. But the key feature, other than their size, are those two little holes, as you can see here and here. They're in the transverse processes, even though they're not very distinctive. And what they do, and you can see it up here when they stack up, they create a passageway for a major blood vessel, vertebral artery. And so when they stack up, the transverse foramina create this passageway, and that's sort of your backup circulation. You have two major carotid arteries, one on the right, one on the left. And immediately behind them, kind of covered in muscle, are these vertebral arteries. So rather than having just two vessels going to the brain, what happens, they all come together, and they try to show it, it looks like an anchor. But the reality is, of course, cervical blood vessels, called cervical gills. So if one of these is blocked, you have three other ways to get the blood to the appropriate place. And that's why, and that's a distinctive feature of cervical vertebrae, not their size, because you can get a very small thoracic and a very large cervical, and you might look size-wise the same. What makes thoracics the easiest one, they're not as big as these big lumbar ones, and the lumbar ones have this thing called like an axe handle or squared off kind of a shape of the spinous process. When you hold the body parallel to the ground, the spinous process goes down. So in thoracic, spinous processes, that's what you look for. In lumbar, the spinous process, even they're obviously larger, goes straight back. And then whenever you have anything, even a remnant of a cervical vertebrae, you have those openings. There are only two other major vertebrae that you're going to have to be familiar with, and I'll find it. Yeah. Found them. I wish they were the right size, but these are the first two cervical vertebrae. This is the atlas, so named. It's really just like a circle of bone. You can see the transverse foramina. And then you have the atlas. So the atlas holds up the globe. That's for the derivation. So, and the two of them work together. So even though these are not necessarily the mated ones, you might remember in the skull, the occipital condyles come down and contact these condyles. And what it does, it allows us to basically move our head up and down, even tilt it a little bit side to side. That kind of joint is the shape of the foot. But the body of the vertebrae is not there. The big thing that I'm pointing at is not anywhere near it. This little tooth-like projection in C2 is called the axis. And it creates a pivoting joint, one of the two pivoting joints you have that allows us to move our head side to side. So they function almost like a car, we call it universal. You know, almost like you can go up, down, side, side. This stuff. So the two of them are considered together. So I wanted to show you those as part of the discussion. I think that's important. So, and they give you all the stuff, the body. I don't use the term centrum, the arch, pedicles and lamina, the opening for the spinal cord, okay, which is the foramen, and the series is the canal, and the ones on the side created by those up and down facets, they make the intervertebral openings. C1 through C7, I beg your pardon, C1 through C7, small and light. The body's interesting. I don't really look at it. When you want to look at it, the opening is disproportionately large because the spinal cord is thickest closest to your brain. And what happens to your spinal cord, it enlarges a little bit, your upper extremities, and then narrows until it gets kind of near the end, then it widens again for the lower extremities. Because what's in the spinal cord are basically nerves coming in and going out. So we have these enlargements, and you'll learn about that, and we will actually learn about it here toward the very end of the semester. The last unit we do is the central nervous system. Okay, so it has a really big opening, comparatively speaking. So you can see the size of the opening, you can see the transverse processes. Okay, a lot of times we'll see this, they call this bifid. It means it's got a fork, and that's because the pull and tug of the muscles on the spinous process. And so these don't look a whole lot different, other than maybe if you in advanced anatomy, we look at the position of the superior and inferior facets. But I mean, it's wide and then proportionally smaller, and then proportionally even smaller here as we go from cervical to thoracic to lumbar. And that really, to me, the distinctive feature is that spinous process going down. That's a slam dunk. Anytime you see it, hold the body parallel to the ground. If that thing's going down, it's spinous. It's got holes for those transverse foramina and cervical. Whichever left is lumbar. So here's the atlas and the axis. You can see kind of like I was holding it, a little bit there like that. So it's just like a big ring of bone, but you can see the foramina. See it from the underneath. And then the axis having the body, and they call it the dens for tooth. And the other name is odontoid process, again for tooth. So, because it looks like a tooth for somebody who's missing most of their teeth. I got just one. Okay. There it is. And this is kind of how they shape up. Voila. And really, that's the part. There's not a whole lot left in this for you other than your ability to identify it. The lumbar, we call it the small of the back because of the indentation, because it's concave rather than convex. Okay, short, thick, that hatchet-shaped spinous process. The opening is distinctly triangular. That's there. That's really it. And in advance, we talk about the position of these facets being more angled this way because it's not designed to rotate kind of as much. That's there. And periodically, when people get to be my age with arthritis in their back, I lifted a box we were sending to Amazon. My wife's got an Amazon business, and it's like, oh boy, muscle went. And I had some things that I said that I would not wish to repeat. Simple declarative statements. Those kinds of things. See, I'm back. I'm only in a good mood because the Steelers somehow won the game. Tell me. I'm texting with my son, and about an hour later he gets back to me. Dad, the Steelers are in first place. He says, that's impossible. I said, what are you going to do? Enjoy it while it lasts. There's not a lot to say about a sacrum, so I don't say a lot about it. I have one, so like, that's a breast bone. So that's why I use the model for the breast bone. Somewhere, if you don't have one, there may or may not be a sacrum. Oh, I mean, you might find one like this, majority attack. That's a sacrum. So all you would have to do is identify that. The interesting thing anatomically is because no longer do the nerves go out side to side, they go out kind of front back. And we'll get to that as we learn more about the idea that the spinal cord ends kind of in the lower back. It doesn't go all the way down to the sacrum, but the nerves continue. That's the reason why we can do things like spinal taps and no lumbar functions. Because the cord is like a piece of space, it's filled with nerves, but it's not a cord. And it's an extraordinarily important diagnostic test, particularly for a disease that is potentially deadly if you don't diagnose it right away, material anthritis. I mean, you don't have a lot of time. That's what you mean. I tell all the classes the same thing. Unless they change the criteria here at Children's Hospital, we have best children's hospitals. You bring a little baby in 104 temperature, one that doesn't get anything. You or I would get it. Children can put up a little more temperature than you or I. The first test they do, if they can't figure out a reason initially, they do urinalysis. Because it's easy to put something over there to capture urine, and the little ones are peeing without having to worry about it. If that doesn't look like a urinary infection, urinary tract infection, what's next? Well, the practice of blood test. No. I stick the kid. You don't have to forget chest x-ray. There's crying and screaming. It's very hard to hear lung sounds. Do they have pneumonia? By that time, now that here for an hour, you haven't figured out why that underscore fever is here. Yeah, you're going to do the blood test. First thing you're going to do is that spinal tap. But this time, we call fever of unknown origin, FUO. Okay. At that point, you better figure out, you better make sure it's not infected. If you don't get my antibiotics, if it is, they may not be around. I'm not saying it, just being very honest. So I don't know what to say from today on spinal tap. So there's really not a lot of to say. There is a lot of anatomy and coccyx, but we really don't have any great specimens to show it. Same with the sternum. I mean, that's a sternum. It's here. Okay. Very important. It's got a little notch there. It's got 3 sections: the maneuvering, the body, the xiphoid. By the time you get like my age, they fuse are all bone. Actually, they're sort of bendable. Particularly this year, baby with asthma. Never seen an asthmatic baby. They do what's called sternal retraction. And it's scary. I've never seen the first time in like a 1-year-old has the better part of 50 years. And you see the sternum cut bending inward. It's almost like bowing. It's scary because it's still flexible. For a baby, and you give them epinephrine, just the way you would do. Like in those days, we didn't have things like EpiPens to be able to do that. So what I use for the sternum is this, easy. Make quite easy. You can see I and the other will label the different parts, the body, the manubrium, the xiphoid, and these are called costal cartilages. Costal cartilages are named that because the costal means has to do with the fact that the ribs are coming into them. And there's some differences that you'll see shortly with the ribs. And that's really what's kind of left. And I'll show you the ribs very quickly. And you'll be all set. So the sacrum, just know it's a sacrum. Coccyx, not even going to ask you about it. It's important. This is important, this area, even though I'm not going to ask you about it, but when I held that up, you could see the hip assembly was attached. That bone is called the ilium. So this is the very famous sacroiliac joint. And what it is, there are 2 roughened areas of bone. One here, sacrum, and look like they're called. They're rough. I mean, it's a very strong hold. That's where the lower extremities, generally called pelvic girdle, attaches to the pelvis. A whole lot different to go over. Not much attachment. So, back, here we go. So this is that same one, manubrium, little notch, jugular or manubrial notch. It's a landmark that everybody has. The beauty of it is it's central. And when something is central, we know it's in the middle. So what we use that as a landmark for is if someone can't breathe because of swelling in their neck, or they have a fracture or they had surgery in their neck, that's where you would put in a tracheotomy tube. Because if you put it to the side, you got giant blood vessels. You have a carotid, jugular. This way, when you're midline, you can't hurt anything. So we use surface anatomy for landmarks. For you guys in nursing and gals in nursing, you will do the same thing. That's you palpate. You feel things. That tells you where to give the shot or where to insert the IV, etc. And just to complete it about the ribs. So here are the cartilages. So first rib, cartilage into the sternum. Second, third, fourth, fifth, sixth, seventh. Then it kind of changes. 1 through 7 we call true ribs because the cartilage goes from the rib directly. Rib goes into cartilage, which goes into the breastbone. 8, 9, and 10, as well as 11 and 12, are considered false ribs because they do not directly, that's the key word, attach to the sternum. 8, 9, and 10, here, here, and here, each have a cartilage. Those cartilages join together and join the one from underneath with number 7. So they are, as well as 11 and 12, false ribs. False ribs, the distinction is made of 11 and 12, which don't have any cartilage, hence the name floating ribs. I'm not going to ask you to, I'm not going to hold up a rib. Is this a true rib or a false rib? Okay, not going to do anything like that. But you should know what a rib looks like. They're relatively flat in this sense. They'll be curved, but you can feel they're very, very light. These are real ribs. Sorry, no sauce. Start. Best place for ribs outside of Las Vegas. Don Diner's driving to McDonald's. It's out. It's like in the dead. It's like 15 miles from the strip. My wife and I went there. They don't do sauce. I think it's dry rather than wet. So if you go to Memphis, you can get it dry or wet there. No. So I'm so happy with my son in the Navy because he's always stationed at different places. So I'll try to give you an idea. These are all ribs. So we start with ribs. Ribs.
I don't have a guess.
No, just going to say identify as a rib. Now, the ribs have interesting stuff, like this is the end that goes into the cartilage. This is called, there's like a head area, and if you look closely on some of these thoracic vertebrae, they'll have a little place on transverse process on the head. That's where, obviously it's not, kind of like just like this. I'm trying to give you an idea what it like kind of like that. You know, it's not the right one. You get the idea. That helps our inhale and exhale. So they have a fancy, they're called, the facet is covered in cartilage. These are called demi-facets because they're tiny. Yeah. The thing that you should be able to distinguish is what a rib, what is not a rib. So these are both examples of clavicles. Clavicle, it isn't the same kind of shape as a rib. When you go over and pick up these ribs and feel them, clavicles are different. They're not really, they look more like a long rope. And they have a big end called the sternal end. It's kind of like almost like triangular, it's like opens up. That's the distinction. You should be able to know the difference. And axial ribs are part of the axial skeleton, okay? And clavicles are part of the appendicular.
So is ribs flat?
The ribs are definitely flat. Clavicles are kind of, I think we do classify them as well. But the reality is, there's almost nothing quite like it. It's the only bone below the skull that forms like a skull bone. Okay, so it forms like a flat bone. So I would agree that you're right. Anatomy is kind of like it's an envelope. That's the most easily fractured bone in the body. Let's go see how it was. My toe, I think how easy it is. Stumble and bang all the time. But if you watch, when you fall, you're always putting your hand down like this to brace yourself. And that moment of force right here into the body. So statistically, it's much frequent. And if you don't fracture, then you get what's called a shoulder separation. If you talk about the joints, but really it's slippage between the clavicle and where it's attached. And this is what I started driving at before. Your upper extremity is only attached here by this part of the sternum, by this, what they call the sternal end of the clavicle, to this upper portion of the sternum. That's the whole thing that anchors your upper extremity. So it's all about movement. It's all about range of motion. Okay, where your hips, that auricular surface down here, very sturdy. So it's about stability. So we want our bottom here, our base to be stable, but we interact with the world for the most part. So this, when you fall, if you don't break this, sometimes you'll separate these. It's a joint where you have two flat surfaces. This is called the acromion process. And this is the clavicle. So this is the acromioclavicular or AC joint. You gotta be careful with abbreviation. And what's interesting about that is when you hear shoulder separation, that's where that occurs. Where shoulder dislocations are different. So here you have a shoulder assembly, and it's very sturdy. So we won't do the humerus here. But so here's the clavicle, and you can always tell. Now I don't ask you what right or left. Right or left stress. Right. I think that's good. Can't look at the Hershey. So much chocolate. So much chocolate. I mentioned my first wife took my chocolate.
Red flag.
I should have known.
I love chocolate.
So I was, sorry. We got 60 years. I'm sure you. But thank you for liking chocolate. My wife now loves chocolate. We're confirmed chocoholics. It's awful. So what can I do over here? You gotta listen to me like, really? You're asking that question? Isn't that the same? Of course. Well, so, how do you tell? This is your shoulder blade. No, it's in the back. You always know when we start to look more closely at this clavicular assembly. I can find a good example. Buried in here. Lower. I'm on here. Actually, the only one that I demonstrate on, I don't know where it went. So I have a little turn on. They typically do. Oh, okay. Well, I have everything but. That's your hip. No, I mean, this is, I wish I had a better specimen for now, but, so this is, and it's not particularly impressive on top. This is the scapula. And the least impressive thing, so it has, when we look at the anatomy of it, and I have, the reason I was looking for one in particular, we have one that's kind of assembled. It's wired together. This is basically the clavicle here acts as a strut to sort of protect from this kind of angle. Okay? So I mean, so it is really supporting the shoulder assembly. So this is called the acromion process. This is the coracoid process. There's a scapular notch. The spine of the scapula is large shelf, it's so famous. And look at the socket. It's not much of a socket. Okay? If you want to see a socket, you go get a hip and look at a socket. So wherever we put that monster hip is here. That's a socket. Your mom said to you, show me a socket. Which one are you showing? That one. There's no question about it. That's an adult-sized socket. Okay? So that's already, that adds to the range of motion, flexibility, and unfortunately, the ability of the shoulder to be unstable. Okay? That's where the problem comes from, is when you trade off stability, you become instability, you're more likely to dislocate. So there isn't much of a socket, and even though what we have when we get to joints, around this socket, which is covered in cartilage, and the analogy they use is good, it's like a golf ball sitting on the table. Okay, there's enough contact to hold it there, but any kind of force is going to knock it off. They have something, and they have it in the hip as well, it's called a labrum, L-A-B-R-U-M. And labrum means lip, and it's a fibrocartilage lip that sort of surrounds it and deepens the socket. We have more than one of those. We have, when we get to the knee, you have two little ones in the knee that we call the menisci or knee cartilage, they deepen the socket. You have one in the hip that deepens that socket. In the hip, showing you that's a fancy name called the acetabular. And so all of those are very, very relevant. Okay. And what this tells you is a couple of things. When we look at one of these that's when you have it assembled, it's called articulated. So these are obviously wired together, but there's not much of an attachment, so it's inherently unstable. Then we look at the socket itself. There's not much to it. And whoever used this, I've never used this skeleton, but one of the teachers did. You can see where the overhang is. There's bone in the back. There's bone on the top. So it shouldn't surprise you from looking at the anatomy that when somebody dislocates a shoulder, it's generally downward and forward, we call anterior and inferior. It has a lot of bony overhang to support posteriorly. Moreover, I don't think it's easy. It's always impressive. Having a big word, I haven't. There are three, what holds this, of all the joints in the body, the shoulder is the one that's secured by muscle more than any other. All the rest of them have other ways to be secured. There are, and it's very famous, it's called the rotator cuff. And most people have heard of it. There are three muscles, one from above here, one from below, another one smaller from below, and one from in front. We have three in the back and one in the front. So again, it's more secure in the back than in the front. So how we name those muscles, and it's something that you will get to, is we take the spine and the scapula, and the scapula usually kind of sits this way. So again, here's where the shoulder is down, which is going to be my left. It kind of sits downward, if you think of it. So here it's in the back. This opening separated by the spine is called the supraspinous, which is above the spine. And the scapula fossa around here. Infraspinous, and when it sits like that, they call this the subscapular fossa. And so to make muscle names out of it, we have infraspinatus, supraspinatus, infraspinatus, and subscapularis. We'll get to those in muscle. But that's kind of a lot of muscles we just add an IS or US. Do we have a name? Those are three of the four muscles in the rotator cuff. The other one is called teres, T-E-R-E-S. Teres means round. Minor, smaller. Why is it so important? Because it inserts into, it makes it part of the cuff, it inserts up into here, into this, which is called the head of the fingers. So that would fit. Obviously not the size or scale. We'll go through some slides. At least I feel better than, oh, it was horrible. I lectured at 1, I got back to the office, usually I sit there and do paperwork, and I did do your quizzes. Believe it or not, I did. I ran them. You're going to get, I'll post the grades. Scouts honor. Vulcan salute. Live long and prosper. No Star Trek fans? What? I know it was a long time ago. Would it surprise you that my eldest, who is now 40, and I used to go to Star Trek conventions in costume? In costume. It's like Halloween. Costume,
Oh, in costume.
In costume.
In Costco.
Not at Costco. I like Costco. Hey, I don't leave home without it. Costco card. It's my wife's Costco card. Hey, anywhere I can shop for food cheap. Sam's Club card. See, I was there yesterday. Moving on. So there's not a whole lot to say about the rest of this. That's important to you folks, the ribs, etc. So again, you can look through these pictures and scroll through. We're already now on the appendicular. It started the shoulder assembly, known as the pectoral girdle, or the hip assembly, known as the pelvic girdle. So that, pardon? I, a girdle as a garment was something that bound things together. So in ancient times, they would girdle things together or hold things, and that's where they derived it. Now you don't see my mom's day. My mom was born in 1918. Women wore girdles. We would have those sort of, particularly if they were a little heavier, it outlined their dress, things like that. It was a different age. If you look at, for you guys looking at grandparents and great-grandparent pictures, you kind of see the way that people, it's very interesting to see the apparel that was then. Like my mom came from, and I always tell my mom's stories and my dad's stories. My mom came from a day and age where she was one of those ladies who at 10 o'clock on a Friday morning had a standing appointment at the beauty parlor. She lived in Rochester, New York the last 20 years of her life. It could have been a foot of snow. She was getting in the car, age 84, driving that mile to get her hair done. I'm getting my hair done. Exactly. To this day. Go Ruth. She's probably getting her hair done now up in heaven. I'm guessing. You wait till Friday at 10. So pectoral girdle and pelvic girdle. I don't know. That's my guess as to the derivation. Short answer, and this is something students need to hear more from professors or teachers. I don't know. Because I've already figured this out. You guys know when somebody's BSing. Admit it. You can tell when a teacher's talking, as my dad used to say, through their chapeau. That would be talking out of their hat. We would say talking out of their ass. Right? You would say, hey, he's talking out of his ass. Okay. Pectoral girdle, attachment of the upper limb. So by definition, even though it's a connector, appendicular skeleton. Mobility, because the scapula is not even attached to the core, just the clavicle, the shallowness of the joint, all the anatomy that was there. Collarbone, another name for the clavicle. You don't have to know, you just have to identify, don't worry about sternal or acromial ends. There's not a lot to say. The scapula and all these angles, again, graduate levels, that's where we look at these kinds of anatomy. And there's interesting because certain muscles attach to certain areas. But for you folks, the spine, the acromion, the coracoid, the notch, okay? So here they are, suprascapular notch. Here's the acromion sits higher than the coracoid, and they're really important because powerful muscles that help to allow you to do all those motions attach there. And then on this side, on the posterior aspect, again, you can see the acromion higher up. You have the spine, supraspinous, infraspinous, and as you saw before, on the anterior surface subscapular. That's a useful illustration. This gives you an idea of kind of what the labrum does. It makes it a little bit, and you'll hear athletes with torn labrums in their hip and in their shoulder all the time. Very common. Very common. Upper and lower extremities are fairly easy. The good news is that you both have the same design. You have the larger bone in the upper portion, be it the arm or the thigh, one, and you have two bones that are effectively attached to one another, two in the forearm and two in the leg. You have your wrist bones, you have 8, your ankle bones, you have 7. And you don't have to know as many in the ankle bones, which are called the tarsal bones, as the 8 uh, in the carpal area or wrist area. And then after that, and I don't even ask anybody about these too much, metacarpals and phalanges are in the foot, metatarsals, kind of like the top of your foot, okay, or the arch of your foot, if you will, and phalanges for digits. So the rest is the same. I mean, there's some special names. The big toe is called a hallux. The thumb is called a pollex. We see that more in muscles because we name like a muscle that helps you lift up your thumb or flex your thumb. Extensor extensor pollicis longus, flexor pollicis longus. So the names they happen to use that in the leg. And the same thing with the big toe, pointing it up. So the one that has the most anatomy, humerus, probably more than anything else. Again, single bone, large and long for the upper extremity, with that glenoid cavity, and it joins both the radius and the ulna. What secures it is more likely the ulna. The ulna has a much more distinctive connection that's very solid. What you'll see, and I do this all the time, is when you flex your elbow like this, okay, your elbow is about as pure flexion and extension as any. When you flex it at 90, without moving the elbow, we can turn our palm down or turn it up. This is called pronation. This is called supination. That's not happening at the elbow. There's a joint between the radius and ulna, and they rotate upon one another, which is different than the leg. The two leg bones stay together. So when you turn your leg in or out, there's no rotational component, bone over bone. And when we see it, it's always bad because when that separates at the bottom of the two bones in the leg, the tibia and the fibula, you get what everybody calls a high ankle sprain. So, I mean, a lot of this is sport oriented, but I did sport medicine for 25 years. So, I mean, I have a lot of context for it, with both children and adults. And like all doctors, there's certain areas you know more about and certain areas you know less about. So I know a lot about feet and ankles and a little bit about knees, not nearly as much about hips. So here they are. So I'll show you the features shortly. That's what the bone looks like. So it's easier. Biol bones are kind of tough. So these are plastic. They're less Biol. And probably were designed to go on one of these and it came apart. Got a new one. Always put it together here. Oh, you can't take. Oh, I know. First, my decorations here and music. My wife now, she used to go out with Witch's hat on. Not anymore. Pretty good. So, how do we know front from back? Well, the key is, if this is the humerus from here to here, wherever that notch is, on the bottom of this or on the bottom of the femur, it's always posterior. And how do we know which side it's on? Okay, well, the head up here is always going to be medial before the midline. The other little clue is this bump. This bump on the inside of your elbow about here is called the medial epicondyle. Epicondyle is not a joint, but it's the attachment of the ligaments secured side to side. When you hear about a baseball pitcher who has to undergo what they call Tommy John surgery, it involves a ligament that comes from your foot, the ulnar collateral ligament, that tears, and they have to put a new one in. We'll do different kinds of advanced procedures to secure it. It used to be 60 years ago, things like that were in careers. It's all changed now with advances in surgery. I mean, it's remarkable. Nevertheless, so this would therefore be, so we have the head. Now, right behind the head, like us, is the neck. There's a distinction that you don't have to know between anatomical and surgical neck. An anatomical neck is right below it. The surgical neck in this is a little bit farther away from the head. It has to do with blood supply. It's not something that's part of surgery. Okay. On the anterior aspect, we got two bumps here and here. These are called tubercles. lesser because it's lower on the medial aspect, greater because it's higher. There's a groove in between them. That groove between the tubercles is the intertubercular groove. What happens in sport all the time is a tendon will rupture in this groove. That's not so much the tendon tears, the tendon pops out. So when you hear about somebody with a torn biceps, it's less likely to happen to TJ Watt. Okay, not this year, but last year, in the biceps tendon injury, called the long head of the biceps, and it goes through this groove. And what happens, the fibers that are holding it in place, when you're trying to pull somebody up and get pushed that way, it's pretty complicated. Another guy in the story is 2005 and 2010 Super Bowls. I wasn't young. Trying to get his last name. He suffered that for those campaigns. So, greater is higher, lesser is lower, tubercles. Intertubercular group. This roughened area is not so distinctive out here. Okay, on the lateral aspect, it's called the deltoid tuberosity. That big muscle. For nurses, this is where you give injections. Very, very close on the upper extremity. So maybe if you got a flu shot or a COVID booster, they went here. So, it originates from here, from the spine of the scapula and this portion, and it inserts or attaches here. So it's more of a posterior muscle. So it allows you to, it's sort of the type of thing that allows you to sort of pull your arm up and maybe a little bit backwards. And then as we work our way down, it gets very interesting. Again, there's a lot of support holding from these epicondyles. They're not part of the joint. Smaller on the inside, I beg your pardon, smaller on the inside or medial aspect, larger medial lateral. And then as we work our way, these guys, they're the security of the elbow joint. They have their own name. They're condyles. This is shaped like a pulley, kind of like an hourglass, would be the way to describe it. The name that they gave to that was trochlea. A trochlear surface kind of an hourglass shape. They named this the capitulum, because it's a cap. And the cap, and I beg your pardon, this is the trochlea, this is the capitulum. The reason they named that as a capitulum or cap is the head of the radius, which is the mushroom cap, sits on top. Why this is so secure is if you look inside the ulna itself, and I had an ulna. It has a little ridged area in the center. So it fits almost perfectly. So, and that locks that elbow. That's why it's almost pure flexion and extension. You have a ridge in the middle that sits in here. Other interesting part, even though radius, so you see the ulna is here, and on the ulna, you just make it out with the wires like you're pulling away. There is a joint, it's cartilage. That's where I'm showing you about that rotation, how that can occur, where effectively you can rotate your palm over. That's because the head of the radius, and it's got that rounded shape fits into this, called the radial notch. Again, oftentimes we name areas for the bone that they are on, or the bone is for the contact. So the head of the radius articulates, that's the term we use, with the radial notch, and it allows the radius of difference over the ulna. At the tips, you have a bump here, rather, first, this is called this is the tuberosity for the biceps. Big muscle, I can't do this. We're all sitting there going, nobody's going, no, you're no, everybody's a big leg. So here is where the big biceps brachii and underneath the brachialis insert here by a common tendon into that tuberosity. So that's a distinctive length. And then the last landmarks are called styloid processes. They look, sort of the styloid process, and temporal bone, little points at the right. So you feel, when I hurt my wrist, really, it's here. So you have a radial styloid and an ulnar styloid. So really, when you press that area, you're still in your forearm, not so much your wrist. And it's finally, as we work our way down, you can see here, the wrist assembly is a lot more oriented toward the radius than the ulna. The ulna doesn't play nearly as large of a role in securing your wrist bones to your foot. So I'll take this, put this away and show you another model. And this model is pretty fairly accurate. So here again, it's just a radius. Here's the radial styloid. So the anatomical position would be like that. Okay. So this would be like my right palm. And you have a series of bones. And you'll see the illustrations in a joke. It kind of looks a little bit like that. There's 2 rows of bones. There's 4 in each row. And typically, we label them from the thumb side to the pinky side, so to speak. In this case, that's lateral to medial. And so, and we use an acronym for you to figure out which bones they are. So there's 2 rows, a proximal row and a distal row. And this, and you can use whatever mnemonic you want. So what a mnemonic is, we have the silent and N. You know, GN. I love silent. XY turned out to be a C. So hopefully no one will be offended. It is a little off color. And everybody uses it, so. Voila. Free to you at no charge. Everybody uses it, we all do here. Okay? So, and what are the names? This is the scapula, and it's a way to remember. When you walk in here and take a practical, you have like you look like that study guide. Write it down. That's why you go, can I write on the test? How many classes do you go in? Can you write on the test? That's what he asked. So stuff that you're trying desperately to remember, you write on the test. It's not rocket science. Anything you can do that makes this easier for you, you do. Right? Scaphoid, because the scaffolding is like a painter's dance on it. That's the highest bone in the wrist. Lunate, it looks a little bit like the moon. Tricletoral, I have no idea what it means. And this little guy is called the pisiform. Because it's P-shaped. It's kind of like the kneecap, because this bone, you can see me doing it here, even though it's attached, we have another special for it rotating. It forms an tendon or a muscle. So this kind of a bone is called the sesamoid bone. The kneecap is similar. The fact that it's moving, it's not necessarily directly attached. So you can feel it a little bit, not the heel of your hand, not the styloid question, right over there. A lot of times you jam your hand and feel that. And then the next ones are called trapezium, trapezoid, capitate. I'm not sure the derivation. And the age is called the hamate. And the most distinctive piece of anatomy on those bones is this shell that's the heel of your hand. That's called the annulus of the hamate. And that really hurt me. You know, pull down, put your hand out, you get hurt. Not that easy to fracture. We'll run through these slides. We're almost done. Happy boots. We're doing good. So there's all the anatomy I showed you there. The joint area is capitulum on top of the radial head. The back, that bony prominence here, I didn't make a big deal out of it. It's called the olecranon process. That's sort of you hit the back. And what's interesting about that is here on what you'll find on the medial aspect, there's a groove right there, and that's where your funny bone is, because the ulnar nerve passes right along there, and it's right against the bone. So it's easy. We all whack it occasionally. The ulna and the radius, and you'll see the illustrations in a second. This is called the interosseous ligament. There's one in the leg. It's a lot sturdier. This one's more flexible. So you have the the tuberosity for the biceps, the head, and now you have the styloid process. Here you have the olecranon process, that big bump in the back. Okay, that opening here. Okay, it's almost like it's like a trochlear surface because it looks a little bit like a pulley. And then on the interior here, you have a radial notch. That's the one that's covered in cartilage. That lets them rotate. And then you have the styloid there. That's the anatomy. Here's that radial notch. Here's the trochlear notch or trochlear surface. Bump at the back of your elbows, the olecranon. And here you can see on the distal aspect, this is for really nearly the entirety of the wrist. And because of the shape of these bones, concave here and convex here and concave here, it gives us a lot of motion, flexion, extension. We can rotate it side to side. So it's a pretty versatile joint. If you're going to work clinically, when somebody hurts themselves, what do you do when you fall forward? You put your hands out, and it'll fracture the radius upward. That's famously called a Colles fracture. A lot in older. We saw so many of them in emergency. Can't begin to tell you. And if they can't get their hands up, it fractures backwards like this. They fall without their hands up. It's called reverse Colles. Famous fractures have names. Just say. And then I'll show you the rest of these. Those are the bones. I use this illustration as well as having the bone model out. For the metacarpals, these are the carpal bones, those 8. For the metacarpals and the phalanges, I'm not going to ask anything. You have 2 in your thumb, proximal and distal. You have 1 metacarpal for each 5 of your fingers. From the lesser fingers, 2, 3, 4, and 5, you have a proximal, middle, and distal phalanx together. And so your big knuckle here is called a metacarpal phalangeal joint. And then these are called interphalangeal joints, proximal and distal. So I'm more focusing on certain bones. Because the feet are the same way. They're shaped a little bit differently. They're the same. This area here, when you hear about carpal tunnel, and we look at that a little bit in the nervous system, has to do with an area that kind of comes right in here in the posterior view, like on the undersurface of the radius and ulna. There's little passageways for tendons, nerves, and blood vessels. So when someone and we get a lot, and carpal tunnel is very common. And now the hip. Now these are interesting, and they're interesting forensically, as you will see, meaning legally. And what particularly, a lot of times we'll find remains of somebody who died ages ago, and all we have are bones. Because the bones don't deteriorate, muscles, tendons, skin, all gone, unless it's something that's preserved. So the hip bones, sometimes called the coxal or os coxae, are 3 bones: ilium, ischium, and pubis. And the socket, distinct name, the acetabulum, and all 3 of them are part of it. So you'll see the illustration. So it looks like it. The ilium is here. The acetabulum is here. You're sitting on your ischium. That's where our weight goes. It's covered by the gluteus maximus. And centrally, they come together. Pubic bones, which are the smallest bones. And just like they're in between the vertebrae, there's a disc here as well. And they're anchored to the axial skeleton by way of those ear-like or auricular surfaces, and this is the famous sacroiliac joint. The ilium, all you have to know is the ilium. It's got other anatomy, not that critical now. the ischium that you're sitting on, particularly the bony prominence called the ischial tuberosity and the pubic bone. So when you stand up, when you put your hands on your hips like that, you're right on the iliac crest. It's very distinctive, and there's a bump in the front and bump in the back that have major attachments, which we'll get to. So, and you'll take a look and you'll see it when it's easier for me to show it than go through the names. So externally, on the outside, you have the iliac crest. You have, these are called spines. Again, fairly good sized muscles attached there. This big opening between the ilium and involving the ischium is very famous. It's called the greater sciatic notch. The bulk of the sciatic nerve exits the spinal cord and comes through here. You have a spine, a point on the ischium, and then a lesser sciatic notch for the rest of the nerve. This is the ischial tuberosity you're sitting on. You can see in color how they all participate in that very deep socket, the acetabulum. The ilium and pubis, they enclose a circular space called the obturator foramen. Muscles and nerves go through there and attach into the lower extremity. So, I mean, that's just those major areas. There's a lot of other stuff that goes on. Here's that ear-like or auricular surface, looking sort of, think of it from looking sort of from the backside or the view, a medial view, as though the sacrum would be there. And you'll see the angle in a second. This eventually creates what's called the arcuate line, not that you have to know that, creates the inlet for the pelvis. This is where the importance is coming. And it's here. We look, not so much true and false pelvis. What we're looking at from a forensic standpoint is these are the hip bones, if we only get one or a part of one, or the femur, if we get the head and neck, we can tell whether it's a man or a woman. Because they're angled differently because they're designed for childbearing in the female. And we look at that area. This is called the pubic arch. In women, it's kind of flattened out. In men, it's much more of an acute angle. The positioning of the bones. This is a more rounder opening for childbirth as opposed to in the male, it is not. And you'll even see the arrangement of the head and neck of the femur is much more, is angled. It's closer to a right angle in the female. It's farther away from a right angle in the male when we look at the shaft of the femur and the head of the neck. So those are all, because a lot of times all you get is the bone. And you may not be able to do DNA testing or anything like that. And so and I don't know if there's as much interest forensically as there used to be. I mean, for a while it was big. A lot of the schools wanted to have their own forensic science department. It really, there's a lot. Duquesne's is very good. Pathologist who was legendary and still alive around 90, Dr. Cyril Wecht, was, I mean, he was part of the team that evaluated the Kennedy assassination. So, I mean, he's been around forever. Years ago, he used to be the president of our staff at the hospital where PPG Place is. Okay, where the Penguins unfortunately lost last night. Yeah. Very unhappy with that. Which we often say, what the puck? It's a hockey term. So look at the difference. Look at the relationship of the sacrum here and here. It's set wider. Look at the opening in the female compared to the male, rounder. That's all part of it. So I just wanted to make that point. The femur is the longest and strongest bone in the body. If you have a femur, multiply by 4, you probably have the height. It contacts the tibia and the patella. The fibula is a strut that helps with weight bearing, but is not truly weight bearing. It is scientifically, but anatomists for some reason don't consider that true. Don't know why. So I'll show you, and we have any number of femurs, and they're easy because everything is big. Lower extremity. So really I'll find one. So many here. So, femur. How do I know which is front and back? Again, just like humerus, notch in the back. I know that's the point for the midline, so I'm on the next left. And distinctive neck. These and ones kind of broken off. Trochanter, greater and less powerful muscles. There's a line between them called the intertrochanteric line. It's very important. Really good. There's a fracture. Down here, this rough area is called the gluteal tuberosity, the big gluteus muscle. This is called the linea aspera. These are the condyles, so there's a fossa between them. So you have medial and lateral. This is an articular surface where the patella sits in this, and it moves kind of with the femur. So when we straighten it out, the patella moves up like this. We bend, it kind of moves down along that surface. So the joint is again between the tibia and the femur, and between the patella and the femur. Fibula, you can see, it's not playing well with it. So we get to tibia and fibula. You better work on it. Oh, lots of big guys. Oh! So, I don't think they're mates to each other, but they kind of sit a little bit like this. Tibia, fibula. Tibia, TB, the big one. Can't get that one right. So, what's on top of the tibia? They're condyles. They're very flat. When we get to joints, you see there's two gaskets. The knee cartilage or menisci that deepen it and expand and move this here. There's two little bumps on top here, which are kind of away, as you on the diagram. Those are the attachments to the cruciate ligament. This is the tibial tuberosity. That's where the tendon head inserts surrounding the patella, insert the injury. The styloid processes are not called styloid processes. They have a fancy name. They're called malleolus, medial and lateral. I say malleolus, fine with me. The fibula has a head and a lateral malleolus. That's it. But the fibula does play an important role in securing the ankles. Here again, the material between them, okay, the interosseous membrane that holds them, it's not like radius ulnar. This is very secure. So when it pops, there's a joint there, and that's a very famous high angle. You can see them a little bit better here in this, articulated part. Still got some remnants of menisci on it that are there. You can see how they hold the foot in very, very well. So while it doesn't play a direct role with regard to weight bearing incomes, it's more stable, about 1/6 of your weight bearing forces to the fibula. We use the fibula as a scrub. That, and when you experience terrible explosion or injury like that, we'll take out the fibula and use that for bone. Save some of those parts. So basically, you have a spare part. This is one of those bones, just kind of a spare part. You'll still be able to walk, but you know as well, find an arm. So all of those are part of it. They secure the foot. Foot, major bones, there's really only 4 to worry about. The calcaneus, where you strike your heel. What's attached to it in the back here is the Achilles tendon, also known as the tendocalcaneus. You have talus, that's your true ankle bone. That's the one that's moved and secured by the tibia. You have a navicular and a cuboid stabilizing the foot on the right and stabilizing on the left. Your sports fans, you hear about a Liz Franks injury that involves this area. These are called cuneiform bones and cuboid with regard to the metatarsals. And this is an anchor point. That happens at Camp Newton, really probably affect this group. Never Liz Franks. Show you the pictures done. You want to look at the bones, you can. Joints next time. More looking at the bones. So I'll show you. So, again, If we look at the anterior view, you can see the greater and lesser trochanter that are there. This is a so-called intertrochanteric line. Gluteal tuberosity for those big gluteal muscles in your buttocks. Linea aspera is a ridge that forms because the muscles in the front are large. Here's the surface for the patella, medial and lateral condyles. Patella is rough on the outer portion, but the portion that's facing in to the femur is smooth. So it's an important joint that adds to stability. It's not essential for walking, but it's very helpful. And then radius and ulna, tibia and fibula, I beg your pardon. Interosseous membrane, not a lot of anatomy. Here are these called the tibial tubercles. They're for the cruciate ligaments. Tibial tuberosity, again, that's where the patellar tendon inserts. It's much sturdier, much tighter fibers. Very distinct joint down here. That's the one that when it ruptures, and it ruptures because of ankle pressure and twisting. And the lateral and medial malleolus. And then when we look at the foot itself, again, calcaneus, talus, navicular, and cuboid, those are the ones you have to worry about. So the calcaneus contacts the floor, the talus highest sitting, calcaneus the largest. This is the one that's enveloped by the tibia and the fibula. The navicular and on the other side, the cuboid, both side stability inside and outside. Here it is on the outside. That's it. So that's all the bone stuff for today. So we have that all done. If you want to look at the bones a little bit for another 10, 15 minutes, I'm here. If you don't, next week will be fine.